Bismillah ar-Rahman ar-Rahim. Here is the last case posted on the group. So what is the case answer? Here we have 22 years old female, and she is complaining of incontinence, and we see that problem on CT. The CT with the recently done, and a urologist who sent her for CT, we found that appearance. This is markedly distended vagina with hypodense fluid inside, so it's likely fluid and not blood, but on CT we could not guarantee that it's completely fluid or there is blood component inside. We see here the urinary blood. This is sagittal reconstruction, and it is very important in the pelvic cases to do reconstruction in order to see the anatomy of the pelvis, sagittal and coronal. Here on the sagittal we found that the markedly distended vagina displacing the urinary and compressing the urinary bladder anteriorly, and here also in the coronal, this is the distended vagina and this is the urinary bladder. And we have here the uterus on top, and then there is something here. There is a small echogenic lesion here, like the calcium. So this is likely a stone. This likely a small stone seen in the end, maybe due to stagnation in the confluence here. This is a stone. The patient has also hydronephrosis, as you see in the videos in the post. Have hydronephrosis and hydroureter down to the lower end, mainly on the right side, and you see here the compression is mainly on the right side. So this is the main problem with her now. She also said that from when she was 14, they do an incision here. They thought that she is imperfect hymen, and they do an incision, but she said that it closed after. I asked her about menses. She said when they do the defloration, there was some blood, but she didn't got menses after that. I asked for previous, this was previous examination on the PACS. This is MRI showing bright signal on T2 with the uterus above here. And this vagina, when we must do T1 to see the consistency of this fluid. It is fluid and it is not blood. It is fluid like that in the urinary bladder. So we have hydrocolpus and not hematocolpus in this case. Why? I didn't know, because she has well-developed good uterus. About the ovaries, I think we couldn't see well on MRI because of the compression, but they are mostly present, but not apparently known. Then came the hallmark of the examination in these cases is to do transperineal ultrasound. Transperineal ultrasound is a simple technique. This is the symphysis pubis. This is the landmark of the examination to see the symphysis pubis, the cortex of the bone, with shadowing posterior to it. So this is the symphysis pubis, and here is our anomaly, urogental sinus syndrome. Here we see the distended vagina with its end tapering with a track passing to the urethra, and then both do a confluence. Here we say the confluence. This is the confluence between the vagina and urethra, nicely demonstrated by the transperineal ultrasound. If we do MRI, there must be a special technique. We must inject. Sometimes there is a vaginal pouch here coming from the urogental sinus, and this is the lower vagina coming with the urethra here. So we can inject gel, but if it is a single opening, We can do micturating micturating MRI in order, semi-micturating MRI in order to try to delineate this fistulous communication. Here also, this is the common confluence, urethra with the vagina, and this is the common confluence. This is low confluence. Sometimes it is high confluence, but here in this case it is low confluence of the urogenital sinus. This is another case posted on our group also from some time by Dr. Alauddin Khalifa. He posted this case. There was hydrocolpus also, and they do CT better than us because they take delayed films, and the vagina here is not obliterated as in our case. I think in our case, why is the vagina distended? Mostly there is a stricture here in that part due to continuous trickling of urine or infection present. So here it's not a good fistulous tract because this means the distended vagina, or maybe the urine come in and didn't get out from the vagina due to narrowing in this fistulous communication. Another case, this is the case posted by Dr. Ala. Here, this is the delayed post-contrast CT, where we can see the vagina distended by contrast. Means that there is communication between the urinary bladder and the vagina, and so the fluid here is just urine. Okay, I will put another case. This case was 40 years old female complaining of lower abdominal pain, and on examination we found blind vaginal pouch. I do ultrasound examination for her. There was blind vaginal pouch, and the patient was married, but she said that she get menstruation with the urine. And long ago she didn't complain when she's 40 years old. Then we do MRI. Here is the uterus, and there is a structure here in the cervix. Mostly the cervix is distended by something, and here is the urinary bladder. Still, we didn't see the communication. So the teaching point that I want to say to you, that once you suspect urogental sinus, you must take thin cuts like those of pelvic floor examination with micturating micturating film in order to detect if there is fistulous communication between, or they both open into a common opening between the vagina and urethra. Here, this is the uterus, and here there is the cervix is distended here by fluid containing structure, and this is the vagina. And then here, just we cannot delineate the vagina separate from the urethra. Here also, this is axial T1. The structure in the cervix is echogenic, like we see here. It's maybe proteinaceous cyst, like Napothian cyst or something like that. The ovaries are well seen, but there is hydrosalpinx present. Again, we could not see the communication. The ovaries are present also. And then on ultrasound examination, here, this is the echogenic cyst intracervical, and this is the normal uterus. And then here the transperineal ultrasound, where we found confluence between the urethra and vagina. Then after that, we do precise MR pelvic floor in order to detect this on MRI. So here we can find that the vagina here could not be delineated to the lower part. Here is the vagina and urethra, and then after that you cannot delineate the vagina. And this is the micturating MRI, where we see here the confluence. This is the lower it is high confluence here between the upper vagina and upper urethra. So this is high confluence and not low confluence as in the first case. And here we inject gel in the lower vaginal pouch. This is a lower vaginal pouch not communicating with the upper one. But here is high confluence of the urogenital sinus syndrome, where we found confluence between the upper vagina and urethra, and this is nicely seen on micturating MRI. Thin cuts. This is vagina and uterus. This is the uterine canal and this is the urinary bladder. Usually in the early stage there may be communication between the urethra and uterus, and then the sinovaginal pulp start to develop and communicate with the upper uterus. This is the hymen and this is the lower vagina coming from the urogenital sinus, and it become two separate openings. If it remain at this stage, we will have high confluence urogenital sinus or low confluence urogenital sinus, both opening into one opening, and this is the normal. Here also, this is the cloacal and urogenital sinus anomalies. You see, you have, this is the normal, but here we have either low confluence or high confluence opening between the vagina and urethra. And then if the sinovaginal pulp does not communicate above with the upper uterus, we may have also the obstructed uterine anomaly. There are many obstructed uterine anomaly, either due to vaginal atresia, vaginal septum, non-communication between the upper part and the lower part, which we termed it vertical fusion anomaly. This is a case of urogenital sinus with the genitogram. The genitography we used to do so much in Abu Rish, in the pediatric hospital. A urogenital sinus anomaly is a defect present at birth in which the vagina and urethra open into a common channel rather than separately. A urogenital sinus anomaly should be suspected whenever there is a single perineal opening and any ambiguous genitalia. If we find ambiguous genitalia or single perineal opening, and many mothers came and said that her girl has only single opening, and we have to do transperineal ultrasound at first step because it solves many of the problems. Urogenital sinus anomalies. In a low confluence urogenital sinus anomaly, the common channel is short and the urethral opening is very close to its normal location, and the vagina is almost normal in length. In high confluence urogenital sinus anomaly, the common channel is long and the urethral opening is internal and the vagina is quite short, and this type may be associated also with anal problems. It may be located far forward, the anal opening is located far forward. And this nice case in utero, cloacal malformation. Here, this is hydrocolpus also, and this is the urinary bladder, and this is mostly it is a case of urogenital sinus. And in cases of urogenital sinus, we may find also allantoic cyst with the case. So this is a case of in utero cloacal malformation. This is also a case, young female, 4 years, and they used to send to us in order to see the distance of the confluence between the urethra and the vagina. Nicely seen. I put here a catheter and inject saline, and we nicely see the confluence between the vagina and the urethra by a single common opening on the perineum. Thanks for your attention, and I think this is better to get information, short information about the case. Thank you.